Good morning. I'm Michelle Weininger. I'm Clinical Manager of the Skilled Caring Center Memorial Hospital. And today I'm going to be presenting a PowerPoint on alternative sleep modalities. This is part of my capstone project. And I wanted to share with you why I chose this subject. I've been a registered nurse for 32 plus years, and I've witnessed many times where there was a misuse of medications to treat sleep disorders and factors that affect a person's ability to sleep. The physicians prescribe medications as a mechanism to address complaints. We see this often where a patient will go into the doctor's office and say, I'm having trouble sleeping, and the doctor will get out his prescription pad and say, well, I'll give you an Ambien, or I'll give you medicine that you can take as needed, and so forth, without researching any alternative interventions prior to medication use. Nurses also use medications frequently because it's a very quick fix, and you hope that by administering a sedative hypnotic to assist someone in sleeping that you're going to have good effect with that. However, that's not always the case, and you might find where the patient has some side effects or definitely have an increased risk for falling and so forth, so you may actually make matters worse by doing this. And we want to look at what is the best practice in caring for our patients. So today I'm going to be sharing with you the knowledge that I've gained in 6 months of researching this topic. And so we'll start out with the alternative sleep modalities. Sleep disturbances. According to the National Institute for Health, 70 million Americans are affected by sleep disorders. And that also is estimated to cost $15.9 billion to healthcare costs on an annual basis. With my experience, I know that sleep disorders are a frequent complaint voiced by hospitalized patients, and that they also have an increased risk for metabolic disorders as a result of inability to sleep. There's been a strong association with cardiac events, and lack of sleep can decrease the immune system's ability to fight infections. We hear this, I can't sleep. Well, these are some of the factors that may contribute to a patient's inability to sleep. In the hospital setting, we have frequent alarms, bed alarms, IV alarms. The patient's basically sick, they don't feel well, they're not comfortable, they might be in pain. It might be noisy, just the process of caring for patients on the unit. There may be conversations and equipment noises and so forth as things are transported up and down the hallway. Patients might be scared. They might be worried. They're not sure what's going to happen to them. And then caregivers will have frequent interruptions to check on the patient. So they may go in to get the vital signs, and then another person might go in to do a respiratory therapy treatment. Another person might go in and do a full head-to-toe assessment. Then they might have medications that are due. So there's frequent interruptions in their care. And so we want to look at some of the factors that may cause a person to not be able to sleep well and address those factors. And if we can do so without the use of medications, then we're hoping that we have good outcomes with that. A person needs to sleep. Sleep is necessary for the physiological restoration and for cognitive and emotional well-being. And sleep health is now included as one of the Healthy People 2020 initiatives. Their treatment strategies. According to the Care Quality Commission, there is a reported less than 50% satisfaction rate for hospital strategies in addressing sleep disorders. Primarily, pharmacological interventions are the #1 treatment option, and the choices might be psychoactive medications that include hypnotic drugs such as Ambien, Restoril, Halcion, anxiolytic drugs such as Ativan, Xanax, Valium, and Klonopin, antipsychotic medications, Haldol, Seroquel, Zyprexa, Risperidol, and antidepressants such as Remeron, Doxepin, Paxil, Prozac, amitriptyline, and Celexa. Psychoactive medications, according to the OSCAR reports that we obtained from long-term care reports and CMS, the average use nationally for hypnotics in long-term care facilities is 7.4%. Anxiolytics is 20.8%. Antipsychotics 25.2%, and antidepressants is 48.3%. I have some graphs here showing the last 2 years of data that we had collected on the unit that I work on, and this is the hypnotic usage. The one graph, I'm not sure what happened with the color differences here, but the straight line graph is the national average is 7.4% usage. And as you can see, the arrow kind of goes up and down. We did have one fiscal quarter where there was no hypnotics used. That was a very successful quarter for us, but trending down to the last quarter of 2016, we went up to 20.5% use on hypnotics. So we consistently average in the past 2 years higher than the national average when it comes to hypnotic use on our environment. So again, that become a goal for me to try to look at what we can do to decrease those numbers. The other one I have a graph on is with the anxiolytic use. The straight line again shows your national average of 20.8%, and we typically are a little below the anxiolytics, but we have had a couple times where we went above that, even as high as 32% in the past 2 years. Those are the two main categories that we see of psychotropic meds that are ordered or prescribed for sleep therapy. And again, we need to look at alternative interventions. The problems with the pharmacological interventions is that there's some side effects, such as increased risk for falls, hypotension, daytime drowsiness, confusion, nightmares, constipation, urinary retention, appetite change, impaired memory, movement disorders, and tremors. The other thing we see is that nurses typically perceive the efficacy of the medications used to treat sleep to be greater than what the patient's perception of the efficacy is. Federal regulations for long-term care. We have our Bible that goes through our regulations, and they're tagged as different categories, and under the tag number F329, that is unnecessary medications, and in that it addresses any drug that is used in an excessive dose, for an excessive duration of time, without adequate monitoring, without adequate indications for use, has a presence of adverse consequences which indicate the dose should be reduced or discontinued, or any of the combination of the above. We are required to document, track, and monitor the effectiveness of the medications and to make sure that it is effective for the intended purpose. We also have to track and document any presence of any side effects. The other thing that we're required to do is attempt any alternative interventions and document those alternative interventions prior to administering any medications. Some of the current non-pharmacological interventions that we use to promote sleep is we try to address comfort needs by giving a back rub, repositioning, adjusting the temperature of the room, encouraging toileting, offering food, drink, ice, heat, things for pain. We coordinate patient care activities to avoid the frequent interruptions by obtaining vital signs and patient assessment with lab draws, dressing changes, respiratory therapy treatments, and so forth. And we might try other medications that are out of the psychotropic med category, such as melatonin. They're known to have a few less side effects, more of a homeopathic type treatment. And then the other one that I'm presenting today is more of the 100% essential oil therapies that can be introduced by either massage or aromatherapy. And so my research project is going to be involving the use of aromatherapy at bedtime. with essential oil of lavender. Currently, there is a lack of high-quality evidence with non-pharmacological interventions, and there's certainly a need for further research studies. In my literature review over the last 6 months, I picked out 5 primary research studies, and I think the findings surprised me. It did not correlate with my initial hypothesis of what I thought would happen. I really thought that patients in today's society would want medications and that they would not be satisfied with alternative interventions for sleep, and they would immediately resort to the medications to treat sleep disorders. But I found the results of the studies here that I will share with you to be a little bit different than that. There's still going to be those patients that want their medications and so forth and feel like that nothing else is going to be as effective. But when we're looking at the overall statistics and data collected here during these research studies, we found that to be a little bit different. There was a randomized controlled double-blind study that used inhaled essential oils and evaluated the effects on mental exhaustion and burnout. And this was conducted in a home setting for patients. And basically they did a questionnaire 3 times a day to describe and rate their symptoms of exhaustion and burnout. And they used inhalation therapy. The double-blind study, they had rose water in part of the inhalation therapy units, and the other was used with lavender. And the participants didn't know whether they were getting rose water or lavender. They were both scented, but the lavender was found to have a more dramatic effect than the rose water, according to the questionnaires that were subjectively completed by the participants. Another study involved a clinical observation crossover study that evaluated sleep deprivation, that the cardiac function in even healthy young individuals with 1 night of sleep deprivation showed a dramatic alteration in the ventricular contractions. This was based on the ECG Doppler echocardiograph studies. And so we know the effects there, and we know that we need to do something with the treatment of sleep disorders. The third one was a quasi-experimental study group that evaluated the effects of aromatherapy on pain, depression, anxiety, and stress. Those are some of the factors that contribute to sleep disorders. And in that study, they did pre-intervention assessments that used the geriatric pain assessment, depression, anxiety, and stress scales. And during that, then they also found that patients reported on a subjective level that their symptoms of pain, depression, anxiety, and stress were reduced after aromatherapy was initiated. A 4th study, there was randomized controlled pilot studies, tested the effects of lavender aromatherapy on vital signs and the perceived quality of sleep reported by patients or the participants. And they found that even though the use of aromatherapy and with lavender consistently lowered blood pressure readings, the overall vital signs were not significantly altered for reporting purposes. However, the perception, again, based on a Richard Campbell sleep quality questionnaire, again showed a dramatic difference in the perceived quality of sleep after initiation of aromatherapy. Outpatient studies with clinical depressed clients. This was conducted in the Non-Western Society, and they were looking at factors that again affected sleep quality and so forth. They used a Likert scale to rate the quality of sleep and correlated that there was a severity of depression. The higher the severity of depression in individuals, the worse their sleep quality was rated. And they looked at factors thinking, was there any difference in cultural aspects between the non-Western society and the Western civilization, and there basically were no differences in the 2 societies there. Looking at the research studies, as I said, I kind of found that I thought the patients would report that nothing was as effective as maybe medications and so forth, but in all those studies it did show their perception of aromatherapy when they scaled it from a pre and post-intervention standard, that they rated it to be fairly effective on a subjective level. So my PICO question was formulated, and it reads, for adult hospitalized patients requiring more than 2 overnight stays, can alternative treatment modalities using aromatherapy improve the perceived quality of sleep and reduce the number of psychotropic medications used for sleep inductions? The theoretical framework I'm going to be comparing to The Theory of Comfort by Catherine Kabata. She first introduced this concept in the early 1990s, and the goal to put comfort back into the forefront of healthcare. There are 3 forms of comfort: relief, ease, and transcendence. And I kind of focused on this because basically we're going to need to relieve their symptoms that's causing them their lack of ability to sleep. And if we're successful in relieving or easing those symptoms, then they should have transcendence and be able to move into the next point and have an improved quality of sleep. So for my research project, I plan to use a quasi-experimental design observation study in a small rural skilled level of care inpatient hospital setting. The population sample will include all adults ages 18 and older that have had at least a 2-night stay within the hospital and that report sleep difficulties. Patients with allergies to lavender, have severe respiratory ailments, or refuse to participate in the study will certainly be excluded, and will honor their resident rights. A sleep quality questionnaire will be utilized to identify those with sleep disturbances, and patients will be asked to subjectively complete the questionnaire both pre and post intervention. The intervention I plan to introduce is the use of a diffuser and administration of 3 milliliters of 100% essential lavender oil that would be placed within a 3 feet distance of each participant during the hours from 8 p.m. to 7 a.m. This procedure I found to be very cost effective, and it is not labor intensive for the nursing staff at all. So they would fill the container with the lavender oil, push the button, and leave it on for the time frame, and I'd ask the patients to complete the questionnaire after they awake in the morning. Data collection and data analysis, as I showed you the graphs there, the baseline data for medication used to treat sleep disturbances has been collected over a 2-year time period, and we'll continue to collect data based on the medications used post-research study. Plan to use a time frame from April 1st to July 30th. Qualitative analysis comparing the use of hypnotic and anxiolytic medications used for sleep will be evaluated with our pre and post intervention, and the qualitative analysis will be conducted with the subjective sleep quality questionnaires that patients will be asked to complete pre and post intervention. So in conclusion, I'm hoping that we can find a statistically significant reduction in the use of hypnotic and anxiolytic meds after we introduce the use of aromatherapy, and that will have improvement in the subjective quality of sleep in the eyes of the patient. I also think an incidental finding that will have reduced falls because of reduction in medications that are at high risk for falls. And I think in conclusion, again, I would recommend that hospitals implement aromatherapy. That gives them a method of trying an easy, successfully documented way of alternative interventions prior to the use of medications in order to induce sleep for our patients. Are there any questions? The final page includes the references sources I've obtained for this presentation. Thank you.
Thank you.